So good afternoon. My name is Alan Lewis, and I'm Dean of the School of Health Professions here at SUNY Downstate Health Sciences University. And welcome to our 2025 SUNY Downstate Disability Awareness Conference. So first of all, let me invite to the podium. Please join me in inviting Jamie Greco, who's our Senior Vice President and Chief of Staff and representative of President Riley's office. Come on up, Jamie.
Thank you, Dr. Lewis. Good afternoon, everyone, and welcome to the first ever SUNY Downstate Disability Awareness Conference. My name is Jamie Greco. I'm Senior Vice President, Chief of Staff to Dr. Riley. Thank you, Dean Lewis from the School of Health Professions, and Dawn Skeet Walker. I don't know if she's here. Dawn, thank you. Dawn is the Vice President of Marketing and Communications. Thanks for your help in planning and hosting this event. Here at SUNY Downstate, we have a mission that embraces excellence in clinical service, educating the next generation of healthcare professionals, advancing healthcare knowledge through research, and collaborating with the community in clinical services, education, and research. Disability is a bona fide component within healthcare, and we are not always explicit in recognizing its unique attributes. In our time together this afternoon, the goal is to understand the difference between a disability and a health condition, because the two are similar and different in important and subtle ways. As healthcare providers, educators, administrators, researchers, we must be clear on that difference. So today, I wish you luck. Enjoy all our speakers, and have a great afternoon. Thank you, everybody.
Right, good luck.
Thank you very much, Jamie. Please extend our appreciation and thanks to President Riley for being supportive of this event. I want to mention that we do have some persons here today other than those in the room. We are joined virtually by persons on live stream, which is a great thing. So we can certainly expand our footprint of who this today's conference gets exposed to. And so welcome to everybody, those of you here in person as well as those of you on live stream. Thank you for coming. As Jamie mentioned, today's event is co-sponsored by the SUNY Office of Communications and Marketing and the School of Health Professions, so it's a joint venture. We'd like to partner up and collaborate as much as possible. Let me take a moment right at the outset and thank everybody who's participating today. Obviously, people who are here as participants and who'll be engaged, hopefully once we get to our panels. I want to thank those who are responsible for our technology supports, new media services, classroom services for the facility and the room setup. Thank you to All Hands in Motion for our interpreters here today. Thanks to my office, who has worked to help put this together. And thanks to all our presenters. So today we have a combination of a few folks speaking like I am here in terms of solo presentations, as well as two exciting panels. So I think you're in for a treat today. Okay, without further ado, I'm going to jump into my first topic, which is talking about the concept of disability. You know, the CDC in 2023 said that 1 in 3 people in this country have a disability, so that's roughly 29%, probably more than most people recognize. The goal of today's conference is to make sure that we have a pretty clear understanding, or at least begin to have a fairly clear understanding of the concept of disability. Because as you know, we are an academic medical campus, and oftentimes healthcare professionals on the medical side are not as explicit about disability as they could be. So we want to make sure we understand exactly what the concept of disability means, because obviously we're providing services to patients in our hospital, at University Hospital Downstate. We want to make sure that those individuals, if they have a disability involved in addition to a health condition, that's recognized. And we're also training our students, the next generation of healthcare providers, to go out and provide services to various populations and various healthcare professions. So we want them to be up to speed in terms of what disability is. So I'm going to talk a little bit about two things. First off, definition and models of disability. Let me first say that disabilities and health conditions are not exactly the same thing. They're very much related. So health conditions would be the broad umbrella under which disabilities exist. But not every health condition rises to the level of being a disability. So a disability requires that the condition be permanent, meaning not curable, and that it poses some functional limitation that's major in the person's life. And so, as you can tell, not every health condition rises to that level. So it's safe to say that not all health conditions are disabilities, but all disabilities have a health component or abnormality or health condition as a part of the condition and impairment that we're dealing with. But also, in addition to that, have those functional limitations in major life areas. So there are three pervasive definitions of disability that we are familiar with. The Americans with Disabilities Act poses a legal definition of disability, which is the one that gets tested in the legal context. When a person says they've been discriminated based on disability, they can file a claim with the EEOC Commission. They ultimately can go to court, and the definition of disability that I'm going to tell you in a second gets tested there. So the ADA says, as per 1990, the original legislation, and then it was reauthorized in 2008, the ADA says that the legal concept for disability is a physical or mental impairment that substantially limits one or more major life areas. And by major life areas, they're talking about things like work, walking, seeing, hearing, any kind of leisure activity a person wants to do. So anything a person wants to do in terms of their major life pursuits, if it's impaired by a significant physical or mental impairment, it can be considered to be a disability. And in addition to that, there's a record of this disability, and the person is considered having the disability, so the person is regarded as having. So it's sort of three prongs. The condition impairs their functioning in a major life area, there's a record of it, and then the person is considered to have it. That's the legal definition. There's also a definition that the Social Security Administration gives us. They give us a definition that's used in disability determination cases. So as we know, Social Security looks at disability and decides who is disabled and entitled to benefits such as SSI and SSDI, supplemental security income or Social Security disability income, which are federal disability benefits. SSDI would be the benefit that one has when they paid into the system, so it's usually a larger benefit. So that benefit is based on how many paid quarters you have in the system over the course of your career. SSDI, supplemental security income, is for persons who have never paid into the system and tend to be have less means in terms of their extent of wealth. But the Social Security Administration definition says that a disability is an inability to engage in substantial gainful employment in one's life, or they call it substantial gainful activity. What they really mean is employment, due to a physical or mental impairment. And that impairment is expected to either cause death or last at least 12 continuous months. So Social Security says that when a person has a physical or mental impairment, and that impairment substantially impairs or limits their ability for substantial gainful activity, i.e. employment, that's what Social Security is thinking about, and it lasts for at least 12 months or is expected to kill the person, then the person is considered to have a definition under the Social Security definition. And the third source of definitions is the World Health Organization, which has probably the most robust and dynamic definition of disability. There's something called the International Classification of Functioning for Disability and Health that the World Health Organization puts out. And they say that disability really is a dynamic interplay of 5 components. The health condition, the impairment, which is the extent that there's a functional limitation, the environment, the person's participation, and the person's coping. So those 5 factors interact in a way that speaks to the person having a disability. And it's very individualized because the person's health condition, their impairment, their environment, their level of participation, their coping is very much specific to the individual person. And so that's why the World Health Organization definition is one that gets used a lot in research and taught a lot in classrooms around just really trying to understand the full extent of disability. It is a dynamic process that involves those 5 components interacting over time. And so that's probably the better of the definitions. The other 2 are a little more narrow because they're designed for more specific purposes, testing legislation or the law in terms of the ADA and determining disability determination with Social Security types of cases. So now I'm going to move a little bit to models of disability. There are probably 24, easily 24 models of disability. I've looked into a lot of those over the years. But there are two pervasive models that you probably hear about over and over again. One, the most popular one, is the medical model. And the medical model of disability speaks to the fact that the origin or the etiology of disability is considered to be a biomedical concern, a pathology in the body. And so the medical establishment that posits this approach says that really the way to deal with disability is through some type of medical intervention. So the medical model really comes at it from a more biomedical perspective and says we must treat this by wielding some intervention that's usually medically based or anchored in medicine. That's a long-standing model. A lot of folks in the disability community don't tend to like it because they said it in a way it implies that the person with a disability is being blamed for their disability. So it's sort of a blaming the victim phenomenon, sort of implicit in the medical model of disability. The other model that you hear about, probably not as much, is called the social model of disability. Came into being in the 70s and 80s with the disability movement in this country. And it really says that disability is, in fact, a matter of social construction, that disability only exists because society has made certain arbitrary decisions about what it thinks people should be able to do to be considered to be able-bodied versus disabled. So the social model says that a person is only disabled because society says we all should be able to ambulate without assistance. We all should have 20/20 vision. We all should have perfect hearing. And that's basically, according to the social model, an arbitrary designation. And so therefore, disability is something that divides people based on these arbitrary decisions that the society has made about what we should be able to do. A very popular model in the disability community has a lot of traction these days. Most folks kind of understand disability from that perspective, that it really is something that we come to based on the things that society says we should be able to do or not be able to do. Now, moving a little bit to something that's not on your agenda, but I want to include a little bit about categories of disability. So this is kind of bonus information. So obviously, the origin of disability can be innate, meaning people can be born with a disability, in which case the disability has occurred, its origin happened while the fetus was in development, or sometimes during the birthing process. Or there's such a thing as acquired disabilities, which means the person is born without a disability, and some life event, usually a traumatic event, causes the disability to happen. And so those are two really different origins or etiologies of disability. And they speak to different adjustment processes in terms of disability. So 6 categories of disability that we think about typically. Psychiatric disabilities, which are basically thought and emotional disorders, typically some difficulty with the brain chemistry, such as mental illness. Developmental disabilities, which is what happens when the normal development is interrupted and a person is born with either spina bifida or cerebral palsy or intellectual disability. And they're called developmental because that disability, its origin happened in the process of the person developing, either as a fetus or in the birth process. Sensory disability has to do with difficulties in perceiving the world, either through hearing or seeing, blindness or deafness. Cognitive disabilities is a flaw in the intellectual functioning or the executive functioning, which usually happens with things like traumatic brain injury, which would be an acquired disability, happened due to some life event, some trauma. Mobility disabilities, difficulty ambulating, which happen in some cases from persons with spinal cord injury have that disability. Again, an acquired disability due to an accident typically, but the functional impairment is the mobility, requires a chair or some other assistive technology supports, or physical disability, which is an abnormal appearance that one has either due to an amputation or to a severe burn. So those typically are the 6 categories that we think about: psychiatric, developmental, sensory, cognitive, mobility, and physical disabilities. So now we're going to shift gears and we're going to bring up another presenter, Dr. Bridget Desport, who is the Associate Dean of Strategic Initiatives with the School of Health Professions. She is going to talk a bit about attitudes toward disability and reframing them to optimize service delivery. Dr. Desport.
So how can we transform our service delivery? Service providers often do not know what to do when encountering a person with a disability. So, as simplistic as this may sound, the first step is to change your attitude, change your perspective about people with disabilities. Changing your attitude means you have to think differently, practice differently, and both can seem quite inconvenient. People with disabilities are capable. That must be acknowledged and supported. That entails actively listening to what is important to them. Acknowledging and supporting them means setting up environments and that facilitate equitable service provision. Changing how you communicate is another concrete step in transforming your service delivery. Again, these strategies sound simplistic, but for some, they are harder than you think. When was the last time you used strength-based language when communicating in your documentation? We focus on the problems that persons with disabilities have because it gives us something to fix. Are you able to defer to the person with a disability and let them express what is best for them? Or is it important to be that expert in that patient-client-provider dynamic? Which brings me to the work that my colleagues and I are currently doing. We borrowed from medical, rehabilitation, engineering, design, public health, and related practices and sciences literature, and aligned them with terms that we found in the ICF, or the International Classification of Functioning, Disability, and Health. And we developed a typology of environmental and contextual factors. So rather than focus on the disability and on the person, what if your service provision involved assessing and intervening with the environmental and contextual factors that are impacting the person from participating in their life activities? These factors are physical, social, societal and organizational, and support and relationship related. If we're honest, we might learn that there is absolutely nothing wrong with the person or the group of people with a disability. They do not require fixing. What is required for those of us in the able-bodied community and service providers to think differently and act differently, and to change their attitudes and approaches to disability. So as I close, before I switch, I decided to give the last word to Judy Heumann, who has been called the mother of the disability rights movement. She died in 2023, and I thought it would be fitting to let her, again, have the last word.
Haven't seen us. Discrimination against disabled people has existed from the beginning of time. And we're in a place right now where, because of other movements, civil rights movement, the women's movement, the Black Lives Matter movement, etc., people are speaking up and out. One of the first pieces of legislation that the disability community really engaged in was getting regulations developed for a provision of law called Section 504. Section 504 says you can't discriminate against someone who has a disability if the entity is receiving money from the federal government. It was the first time that many of these young disabled people felt a part of something and really felt that they were making a difference, not only for their lives, but for the lives of many others. There is a shift, I believe, going on in our society where we're looking at race and gender, equality and disability as issues that we need to address, that diversity is something that makes our companies stronger, that diverse businesses provide better services for customers. I also am a very big believer that The disability rights community cannot stand on its own. We need to be working with all other movements, and we want all other movements to be inclusive of disabled people. If we are actively learning and working together, we can do things like make sure when housing is being built in our communities that it's accessible, not just for people who have physical disabilities today, but if you're gonna have a physical disability tomorrow. I think having a disability really has allowed me to do and get in touch with so many things and opportunities that otherwise would not have happened. People look at us as the label of our disability. And it is a part of who we are, but it is not who we are. My name is Judy Human, and this is my brief but spectacular take on the disability rights movement.
Okay, thank you. Dean Lewis is coming back.
Thank you very much, Dr. Desport. If you're interested in more testimonials like Judy Human, there's a book written called Enabling Lives that's written about biographies about 6 prominent persons who are advocates of disability. That's worth getting. I have a few copies upstairs if somebody wants to borrow one. So thank you, Dr. Desport. We know that attitudes are a big issue in terms of the disability community being accepted. Stigma is a big barrier to persons with disability. And one of the things that came up with your presentation is the idea that the deaf community then consider themselves to be disabled. They're very empowered and self-determining. But by definitions, they still are, but they don't consider themselves to be, so that's fine. So a couple of things. So one thing you should be seeing today as we go forward is that we have many voices in this process today. We're going to have 2 panels in a little bit after I'm done with my little comments here. 2 panels, one that's going to address what's happening here at Downstate in terms of disability. And the reason we did that panel was because we wanted to make sure that we understand what's already here. You know, oftentimes we say, are we doing enough in this area? So one of the first things you should do is take an inventory of what's happening now. So this panel will give us a good sense of all the disability efforts currently underway at Downstate. So we can, once we know the current status, the baseline, today's functioning, then we can build out and do more in the future. So when we get to the panels, we have lots of different perspectives, lots of different experts will be in the picture in terms of the voices you'll hear. So I'm going to say a few things. We'll have the first panel, then the second panel is going to focus on contemporary perspectives of persons with on the concept of disability, which really will be a great treat because we have 2 disability experts in from outside of Downstate. We have a family member perspective and a person who has a disability. So we'll get some good, rich information there. And then we'll have a break between the 2 panels. And today is sort of a short exposure, but we hope to do more in the future and build out from what we started today. So my charge now is to talk a little bit about interventions for disability, very briefly. And Dr. Despot, you did a great job. We're on time. So we're doing, and even though we started late, we are on time. So interventions for disability. So I want to say 2 things, the 2 types of interventions, and then I want to talk a little bit about the values that most disability service systems should embrace in providing these interventions, also known as rehabilitation. So in the rehab field, we don't really call them interventions so much. We say these are rehabilitation strategies or rehabilitation interventions. So there are really 2 types of interventions that people with disabilities receive. The first is called restoration. And restoration is sort of a basic medical kind of intervention where the person receives a medical or psychological intervention to try to improve the functioning of the person in the face of the disability. So whatever the extent of functional limitation is with the disability, the restoration process tries to mitigate that as much as possible by deploying an intervention targeted to the person to make them better able to function. And there are a range of things that would be included under restoration. Therapy, traditional medical types of modalities. And so that's sort of the first line of rehabilitation strategy that happens. And then the second piece is something called adaptation. And what that means is we're dealing with the person in their environment. And so what does this person really want to do? Because the idea with rehabilitation is to try to maximize the person's functioning to participate fully in those areas of that person's life that they want to participate in: work, leisure activities, social activities, whatever it may be. So the adaptation is designed to deal with the environmental constraints that are in place that limit the person's functional ability. So sometimes we make ergonomic adjustments, sometimes we deploy assistive technology and various devices, things from the rehab engineering community that allow the playing field to be leveled a little more in terms of the person's functioning. So in rehabilitation, we primarily do two things: restore as much as we can the person's ability to function, and then we modify the environment through technology and other types of ergonomic adjustments to level the playing field as much as possible. And between those two options, typically a combination thereof, we try to mitigate the extent of functional limitation as possible. The reality is that, we make a big deal about being disabled, but the reality is that there's no human being in the world that doesn't have limitations. There's some really talented Renaissance people, but nobody does everything exceptionally well. So we all have limitations. So a person with a disability just has a limitation because of a physical or mental impairment that poses that limitation in a major life area. But we're all basically in the same boat. So there really should be no difference. So the stigma thing should really not be a thing. So in terms of values that most disability systems try to embrace, and these are the principles, the philosophical orientations, the values that they want to embody as they're providing services. And the first is assets focus. So as I just said, we all have limitations. So a disability provider who knows his or her or their stuff really starts off by saying, okay, this person has a disability. What are the strengths or assets does this person have? So instead of starting with the glass is half empty, you got all these deficits and all these functional issues, let's look at what you do well, and let's identify those assets, because those assets become the foundation, the basis upon which we build a plan to improve your functioning in whatever your limitation areas are or deficit areas are. So assets focus is really the first principle that most systems try to embrace. And then the whole concept of individualization. So no two people even with the same disability are the same. So services have to be designed to be very individualized. They need to speak to that person's individual needs and build on that person's very individualized strengths and assets. No cookie cutter approach. And then there needs to be the invoking of natural supports. We know that supports from the natural environment, family, people you know in your own community, they're typically superior to supports from people you don't know, artificial supports. So most service delivery systems try to use natural supports to the extent that they're available, and everybody has some natural supports in place. Services are usually much better if they're located in the home community. People feel much better when they're not displaced from their community and they're functioning in their community of origin. So the home community piece is very important. And then there needs to be a continuum of care or an array of services that span a continuum from more restrictive services, such as hospitalization, when a person needs that level of structure and intervention, all the way down to community-based outpatient services, where the person basically has a therapist to facilitate them doing what they need to do in terms of getting better with their disability goals and objectives, the outcomes they want to achieve. So ultimately, with disability, the idea is we're trying to strive for full adjustment of a person with a disability. That means the ability to fully participate in one's life, in the areas of one's life that that person chooses. So adjustment is usually thought about along a continuum. The first point on that continuum is awareness, because the person first has to be aware and understand that they have a disability, and that having that disability means certain limitations, but also, more importantly, assets. So the awareness piece happens first. It's a cognitive piece. The person has to understand, yes, I have this disability. And then the second point on the continuum is acceptance. And acceptance happens when the person understands that, yes, this is me, this is my life, this is what I have to deal with, not being in denial about it, coming to grips with the assets and limitations that are at play in your own life if you have a disability. And then you move to the point of adjustment. And adjustment isn't a point that you reach and always stay there. A lot of folks don't reach adjustment and have a steady state status where they stay there. Sometimes they vacillate back to acceptance for a period of time and then go back to adjustment. But a hallmark sign of a person who's adjusted to disability is they are able to fully participate in their life, and they're actually doing it. They've decided they're going to re-enter all the areas of their life space that they want to be involved in, and they're doing it. And you can see they're striving for that optimal quality of life. So the adjustment process starts with awareness, moves to acceptance, and then the adjustment begins to kick in. It's very individualized, very different for each person. And it's something I alluded to early on. Adjustment to a disability that's there at birth, an innate disability, is going to be different from adjustment to an acquired disability. If you're born with a disability, then having that disability and the limitations that come with that will be all you know. That's your norm. Alternatively, if you're not born disabled and you're quote unquote able-bodied, and at a certain point, there's a trauma that happens, a car accident, brain injury, spinal cord injury, whatever, heaven forbid. And at that point, that has to become your new normal, but it wasn't your normal before that event. That's a different adjustment process, as you might imagine. I'm not saying one is more difficult than the other, but they're just different processes, which underscores the point that adjustment is very individualized. And so with that, I'm going to turn the microphone over to Dr. Efekona Newware, who's our chair of occupational therapy. He's the moderator of our first panel. We're going to ask our panelists to come up front. We have 7 panelists and Dr. Newware. Again, this panel is going to focus on what's happening at Downstate in terms of disability. And Dr. Newware is going to moderate the panel, and we're going to have about an hour to hear from each panelist and have a Q&A period. And then we'll take a break, a brief break, 15 minutes. We have some refreshments in the back, I think. And then we're going to, and also restrooms are back there. I forgot to say that early on. And then we're going to do the second panel, which is contemporary perspectives on disability. So, Dr. Newware, panelist for number 1 panel. Come on up.
Hey, Jack. You got Harris plant.
Good afternoon, everyone. I'm your moderator for this panel, and I hope to facilitate a rich discussion with my esteemed colleagues as we share what's happening at Downstate related to disability. Before I begin, I just want to acknowledge Dawn Walker and all the folks in the Office of Marketing and Communication for sponsoring this event and pulling together this program so seamlessly. I also want to thank Dr. Lewis, Dean of the School of Health Professions, for his unwavering leadership. Because of him, we're all gathered here today to interrogate our assumptions on disability and generate momentum that advances our efforts for a more inclusive learning and work environment. If you want to hear more about Dr. Lewis's career in disability services research, check out his featured faculty profile in the latest research posts. Oh, by the way, my name is Efekona Newware. I'm the chair of the occupational therapy degree programs here at Downstate, where we have both entry-level master's and a post-professional doctorate in occupational therapy. And in my years as an occupational therapy educator and a clinician, I've developed a view of disability that may be more nuanced than the general public. Occupational therapy practitioners think of disability not so much as an impairment, medical condition, chronic illness, but more as the interaction between the person, the environment, and the activities that are done on a daily basis. And it is, in fact, the mismatch between the person and the environment that is truly disabling, be it in the physical, social, or virtual environment. Each of the panelists here would agree that it is our goal to reduce the barriers in the environment for people with disabilities so that there's greater participation in higher education, work, and everyday life. It's known that about 1 in 4 adults in the United States, or over 70 million people, report having a disability. And sometimes these disabilities can be seen, while other times the disability is invisible. Did you know that 30,000 SUNY students report having a disability? Or about 10% of students enrolled across all SUNY campuses? The actual number of students with disabilities is likely to be higher if we also consider those students who choose not to disclose their disability. The decision not to disclose could be for a variety of reasons, such as stigma or the lack of awareness of the services available. Under the direction of Governor Hochul, SUNY has invested $10 million per year to support students with disabilities. This is critical funding that increases access to higher education. For example, campuses can staff their disability and accessibility offices with service coordinators and learning specialists. New equipment and technology can be purchased to improve digital accessibility. And programs can be implemented to support faculty to improve accessibility of their course content. So I'm happy to have our panelists here today, a diverse group of individuals representing education, administration, and practice here on campus. So let's transition to hear from them about the programs and initiatives happening in their work areas that support students with disabilities and people with disabilities to ensure greater participation in higher education and in society. So I will ask the panelists to introduce themselves, provide an overview of how disability relates to your work here at Downstate, and share one actionable step in your work that is happening or in the works of happening that advances the culture of disability inclusion on campus. I suppose we can start right here with my colleague, Dr. Vikram Pekpatan.
Thanks so much.
Testing, great, thank you. Thank you, Dr. Nawar. My name is Vikram Pekpatan. I am an occupational therapist from New York State, licensed and registered. I am a faculty member of the occupational therapy program at SUNY Downstate for a little over 8 years. I am also a practicing occupational therapist in New York City, including Nassau and Suffolk County, which is BOCES, the special education or school education systems of Long Island. A little bit about my work here within the Department of Occupational Therapy. I teach pediatrics, specifically school-based pediatrics, assistive technology, and the foundational courses. To start with the first question in regards to disability and the division we represent, as my colleagues have stated, Dr. Desport, Dr. Nawar, Dr. Lewis, disability is a very broad, complex. I'm going to share one aspect that has not been shared thus far, and that's the idea of both rehabilitation and habilitation. We talk about wanting to regain skills that we've lost. How about maintaining skills that we have? There's a different idea or different lens that occupational therapy often tries to focus on, is the idea of maintenance, prevention, and quality of life. So habilitation is just as critical as rehabilitation. Why wait until we've lost something versus addressing the factors to strengthen, to bolster, to emphasize what we can do? So very much a strength-based approach. Something that we do very well in the occupational therapy program at SUNY Downstate is that we teach our students to empathize. Professor Richard Sable has a unique way of fostering empathy when it comes to wheelchair access and power mobility by having students actually try out the different platforms that they'll once recommend to clinicians. I think this is a pivotal moment in realizing the importance of empathy and the importance of really understanding the lens of disability from those that we serve. So that's one aspect of experiential learning that we're quite proud of. The second aspect, really quickly, is the early intervention program within Downstate for occupational therapy. School-based practice or pediatric occupational therapy is the largest employable field nationally when it comes to occupational therapy. So why not introduce the idea of early intervention to our students before they become practitioners? Speak to parents, understand the impact of congenital, as Dr. Lewis stated, as well as acquired injuries from the time of birth, from the time of development and so forth, and also begin to reflect on the impact of disability as a lifelong process, but not as a moment. And And the last aspect I really want to share about disability and what's happening in occupational therapy is the idea of a point of view. We can read chapters, we can read articles, we can publish, we can talk out of our shoes. But to really understand, as Dr. Desport stated, is to actively listen, but not just to listen, but rather to integrate what you've heard. That's an important aspect of our program where we have individuals with disabilities come in and talk about Parkinson's, talk about MS, talk about spina bifida and cerebral palsy. Our students are not given any opportunity to not reflect and not to empathize, but instead they're given moments of being humans and dignifying disability. So in summary, that's what we do when it comes to disability within the OT program at Downstate. Thank you.
Wonderful. Thank you, Dr. Pekpan, for highlighting different aspects of the occupational therapy curriculum and sort of the orientation that we help students adopt in viewing disability. I would like to continue down the line to your left.
All right. Hello, everyone. My name is Jason Vladescu, and I'm the chair of the Behavior Analysis Program. And I'm the new kid on the block, so this is a new program that we just launched last semester in the fall. So I'm also new to Downstate. But just thought I'd share a little bit about my thinking about that program and its contributions to the current discussion here at Downstate. So I think thinking about the intersection of behavior analysis and disability, I'm trying to set up the program to do a couple things. One would be ensuring that we have and equip future behavior analysts with some really strong training, right? So that would be ensuring that they have a kind of modern, practical, and evidence-based approach to ensuring that their future clients that they work with really flourish. And the second is that some of the reason that this program was started here at Downstate was to try to address some pretty critical service gaps. So, I'd say over the last 10 to 15 years, we've seen a pretty robust demand for behavior analytic services. However, many communities, including a number of areas in New York City, remain kind of really severely underserved. So one of the hopes of this program, the behavior analysis program here, is to help develop a diverse workforce of really highly trained behavior analysts to kind of fill this service gap. In addition to that, I kind of have a vision. I was just thinking back, seeing Harris here, about when I interviewed, and I think that SUNY Downstate is pretty uniquely positioned as a health sciences university, where at least my hope for the program is one involving collaboration and interdisciplinary collaboration, right? And that I think that this is a unique environment because these types of environments, that should be built into the DNA of a place like this. And so, I think for our students in the program, that's part of my vision, right, is to really make learning to approach care in a more holistic sense. And, I think, we're nicely positioned to do that in the School of Health Professions, as well as some other schools, colleges, and departments here on campus. And the last thing I want to mention, too, is in that we're serving the future trainees and the current trainees and future behavior analysts, right, are going to likely work in a pretty diverse urban population. And so, one of the highlights of our program, too, is, to make sure that we're emphasizing and directly addressing the importance of culturally responsive care. And, to make sure that communities, families, supports are kind of integrated into the therapeutic process, and wanting to ensure that we're really training, highly competent, ethical, and culturally responsive clinicians for the different communities that they'll serve. So I'm really hoping that this new behavior analysis program will really provide a kind of a powerful ally here in kind of, bridging some service gaps and really delivering kind of highly effective care and support to those who seek such services. So thank you. Looking forward to this continued discussion and hearing from my fellow panelists here.
Wonderful. Thank you. It was no small feat to get the ABA program off the ground and addressing a critical need within the community. So thank you. So we'll continue down the left.
Hey, I'm Jordan Weil. I am not Jeremy Copeland. He's out sick. I am a psychiatrist. I've been working at SUNY in some capacity for the last couple of years. I'm currently the attending psychiatrist on the intellectual disability and intellectual and developmental disability and mental health unit at Kings County. That's an adult inpatient psychiatric unit for folks with intellectual disabilities or who have the autism spectrum disorders, who are also having mental health problems, and those mental health problems are making it hard for them to safely stay in the community. It is an acute hospital, so it's not like we try to keep our stays around less than 2 months.
Dr. Weil, if I just can ask you to speak a little closer to the microphone.
Okay, sorry. So we try to keep our stays for around less than 2 months. And before this, I was working at the Kingsborough Psychiatric Center, which is the state hospital, which is also a training site for SUNY, where most of the patients have a schizophrenia spectrum illness or bipolar disorder. So sort of a fairly different set of challenges for being able to safely stay in the community. Working at SUNY, most of my contact with SUNY is through working with the trainees, whether it's medical students, residents, or some of the psychiatric fellows, the psychiatry residents. And sorry, I don't have more of a speech than that.
Well, thank you. And next up, I just want to pull up this presentation for Dr. Huberman.
Thank you very much. Can you all hear me? Okay. My name is Dr. Harris Huberman. I'm a developmental pediatrician. I direct the Division of Child Development in Pediatrics in College of Medicine here at Downstate. I'm going to crane my neck so that I can coordinate my talk. Basically, I'd like to talk about what we do in our own child development clinic and the services we provide. I'd like to talk about the Brooklyn LEND program. And then I'd like to talk about where we need to go and actionable approaches. Mm-hmm. So in our own clinic, we see about 350 children with autism per year, okay, with neurodisabilities, heavily autism, as well as learning disabilities and other disabilities. We do initial evaluation, we do ongoing management. But especially, we have a team, and we're doing care coordination, reaching out, thank you, in terms of connecting with the school system, Committee on Special Ed, OPWDD, yes, Office of People with Developmental Disabilities, New York State's overall program, behavioral services like ABA, that usually not available through the special ed system, but through insurance and working to get that. We coordinate with Dr. Joan Hittleman's Child Mental Health Clinic in terms of both evaluation, but especially advocacy, and basically fighting with the Board of Ed to get the right things for our patients, but also neurology, GI, feeding therapy, child and adolescent psychiatry. And we're also a training site. We're a training site certainly for pediatric residents. We also have psychiatry residents rotating through with us and fellows, as well as an array of other observers and medical students. So I'd like to talk about another aspect and something we started, I guess, about 4 years ago, where we applied for a HRSA MCHB grant for the LEND program, Leadership, Education, and Neurodisabilities. And this is a multidisciplinary training program to address, basically to address disparities in both evaluation and care for individuals with neurodisabilities, especially around autism, but all neurodisabilities. And the idea of it is to have, that it's multidisciplinary, that we have physicians, social workers, psychologists, speech therapists, occupational therapists, physical therapists, and others training together, but also side by side with family advocates and self-advocates, individuals themselves with a neurodisability, both as trainees and in fact as part of our faculty. So it involves didactic sessions, it involves practicum experiences, both, for example, rotating through our clinic. Also, we've had LEN trainees coming through the IDD clinic at Kings County. They do a capstone project, putting this together. And then also, we run workshops and conferences, and I'd just like to mention some of those. In last September, we continued our tradition of having an annual autism fair, and this was co-sponsored by LEND together with our Division of Child Development, where we had informational tables and as well as fun activities, clowns, bubbles, art activities for children and youth on the spectrum. More recently, actually December 6th, last month, we had a conference on neurodiversity and the transition to adulthood. And we were looking both at early transitions and why early intervention matters in terms of then building for transition to adulthood in all the many aspects, including heavily mental health. We had 360 participants, and it was quite gratifying. But I'd like to turn to what I've kind of charged us with, which is to talk about what are the problems here and what we need to do. And I think working in my own clinic, I'm acutely aware of just how much more we need to do to meet needs. For example, as a physician, I think I matter a little bit in looking at the medical aspects, but I've quickly learned that it's the support team, it's our social workers and our care coordinators who often are the most important person in the room in helping families. But first of all, I'd like to talk about what I became aware of in the transition conference and just clinically, what do we do as our patients age out and the many problems they face? And one of the questions is, at Downstate, are we serving adults with neurodisabilities? And this is I asked for and reviewed data on all Downstate patients, this was the last 2 years, who have some type of a neurodisability diagnosis. And what was striking, and it matches data across Brooklyn from our Health First, that physicians pay attention to neurodisabilities as it's showing up as a diagnosis in their encounter forms heavily in the first years of life, but only 18% are adults. In other words, something is happening. Are people, I don't think neurodisabilities are going away. Are they leaving Downstate maybe, or are we simply not on the radar for providers? And so one of the questions as we talk about transition, there's all sorts of ideas of how you're supposed to plan it and reach out to adult providers is, are those providers there who are trained and comfortable and have, and very importantly, have the supports to work with patients with neurodisabilities? There's other major problems. One is accessing mental health care. And we have major issues where we have our patients, let's say with autism, who are suicidal or have clear depression. We would like to get them involved in psychiatry, and they hit a blank wall. No, they go over to Kings County, and they're told for various reasons, no, you have an autism diagnosis, we don't see you. Okay? So trying to find anywhere where you can get mental health services for neurodiverse individuals is quite challenging. The other question comes to, I talked about how we coordinate with other disciplines, but are we truly providing true integrated care. And thinking back to Alan's mention of the ICF definition of disability as not just being the medical part, but looking at the environment and the social supports and the need to address them. As I said, that's often the essential part of it. So are we bringing together both primary care, specialty care, but especially care coordination and patient navigation? So in terms of what do we need to do, I'd like to talk about something we're calling the Lifespan Clinic Initiative. And the idea of this is that it's a clinic specifically for neurodiverse patients that would bring together primary care, both in terms of pediatric care, and I hope soon family medicine, internal medicine, working side by side with specialty care, that we would be co-located, that we would have the possibility that as we each see our own patients, we can talk to each other and coordinate. A patient with autism has a medical issue, we can talk to their primary care provider and get it resolved. Rather than what usually happens, which is we send patients back and forth and spend all of our time trying to track down what happened, did they get the referral, why didn't they show up, this or that. But a key part of it is to build in behavioral health. We are hoping we'll have a BCBA who will directly provide services, run groups, guide both families, providers on plans, work throughout the hospital, but especially be there in that program. And then very essential is having a family advocate, someone who does care coordination, a patient navigator. In my time when I was in a primary care community health center, they were called and still are community health workers. I've just learned they're billable. And the idea is that this would be a very important person, a person who has lived experience, someone in their family has autism, they get it, they know the systems, they can best communicate with families. I've certainly seen better than I can what is autism, what are the services, what are the supports, and follow through after they leave the clinic, follow up, check with them, are things happening, and making sure. And then very importantly, that there be a seamless transition from pediatric to adult care, that we would have we're starting with peds, would move to a family medicine and eventually internal medicine where this same model would be there and we could talk to each other, pass along a patient in a warm handoff, that there's not this to send it out, go find a provider, which often is a disaster. Certainly the point of this is training and capacity building, training residents, training psychiatry, neurology, that we're all learning together, bringing in LEND trainees who are there. I've learned to value it. We're training them. They're training us. They're also, when we have OTs and PTs, we're learning all together and each bringing their own expertise, including family advocates and self-advocates. And finally, that we can do this, and especially, and I'm going to learning this from Jason, is there a way to make this a financially sustainable approach? And the hope is that if you do bring and properly bill for both individual and group behavioral services, this can be something that is sustainable. So this is our model, sorry, hand-drawn about last week, where we're trying to put together in the middle that combination of specialty, primary care, but especially that support. But then the point is, this is a hub model where you're then using that to connect with all other services outside in the community, family support, a family support project I'd like to mention, part of LEND, other specialties, community organizations, transition programs and vocational training and so forth. So looking ahead, we're proposing a small model, get this going, see if we can go. We hope we have some outside funding to support it. But looking at, especially as we're moving toward a new, stronger downstate, I'd like to propose that we look at behavior and neurodisability services as a very central part and a need to address what is a huge need in our community, as well as an opportunity to reach out, to make something that's both financially sustainable, but also quality care, gets our name on the map and gets it out there, building in very importantly, this family advocate and care coordination. I think that's for this specific model, but as I talk to my primary care colleagues, it is huge for everyone. We really need to have more community health workers, part of what we do to connect with the community, that we can provide behavioral and ABA and mental health services. And to do that, I'd like to put in a plug for Jason's program, and we are very much hoping that, for example, this lifespan clinic would be a practicum and training site for the ABA trainees, but in the process, bringing in both more students. I think we need to have more faculty and finding the support for that, but integrating it with the lifespan clinic. So if I could close with just saying, I think we have a need to grow Downstate's presence in the community and engagement, and I think this is a way forward, and thank you very much.
Wonderful. Thank you. Thank you for sharing your initiative on the Lifespan Clinic, and it sounds very encouraging how will be able to provide comprehensive and integrated care. So let's continue.
Hello. Hi. Hey, everyone. My name is Zachary Durkin. I'm the Assistant Director for the Office of Employee and Labor Relations. Myself and my coworker, Stephanie Desiree, we serve as the campus designees for reasonable accommodations under the Americans with Disabilities Act. So in October of 2023, our office took oversight of the ADA reasonable accommodation process. We streamlined the procedure to align with SUNY-wide practices. We implemented regular reviews of active ADA cases in collaboration with our general counsel. We also partnered with the Job Accommodation Network, also known as JAN, to ensure consistent guidance. So the ADA requires employees to provide a reasonable accommodation that allows employees with disabilities to perform their essential job functions. Accommodations can include flexible work schedules, assistive technology, or workspace modifications. And it's not just a reasonable accommodation for employees, it can also apply to job applicants as well. So these solutions or these accommodations must be effective, but should not pose an undue hardship to the employer, which is an extremely high burden to justify, right? You know, we're an institution of over 5,000 employees. We have what, $1 billion, right, from Governor Hochul. So it would be a very high burden to say that we cannot grant an accommodation, due to undue hardship. The key to this is the interactive dialogue or the interactive process between the employer, the employee, and myself or Stephanie, the designee for reasonable accommodations. So Stephanie and I work closely with supervisors and the employees to find a solution that can support both the employee's success and workplace operations. Currently, Human Resources is advancing our strategic plan under New York State Executive Order 31. This was signed into effect by Governor Hochul about a year or two ago. This plan focuses on improving disability inclusiveness and increasing the hiring of people with disabilities at SUNY Downstate. This strategic plan has three main objectives, and that's to make the workplace accessible for current employees and potential employees, proactively connect with people with disabilities for open positions, and communicate support and inclusivity to employees and the public. And so to meet those objectives, we are doing a lot of things. We are ensuring that our websites and job postings are accessible. We're creating annual trainings on how to request accommodations. We're surveying employees who already have approved accommodations to track their satisfaction. We're offering internships with individuals who have disabilities. We're publishing our strategic plan and updates on our internal website. And we're integrating these goals into trainings, orientations, and webinars. And our plan is to share this strategic plan with our unions, vendors, and contractors. And of course, ensuring that non-discrimination and equal opportunity statements are included in all appropriate documents. Thank you.
Thank you.
Hi, everyone. My name is Patricia Napolitano. I'm the Assistant Vice President of Student Affairs here at SUNY Downstate. I've been here for less than a year, and my experiences have been in the student affairs field, but also overseeing student accommodations, both here at SUNY Downstate and prior to that. So I'm going to talk a little bit about where we at currently, and kind of go through that. So I want to start out to let everyone know 4% of our students campus-wide have some type of accommodation. So they've come through our office. And when we look at our colleges, our College of Nursing has less than 1% of their student population receiving accommodations. Our School of Public Health is 2%. The School of Health Professions is 6%. The College of Medicine is 6%, and 3% in the School of Graduate Studies. So that's just kind of giving you a snapshot of our campus. We looked through all of the students' diagnosis, because that's something that we are tracking as well. And we have 29% of our students identify multi-variations of needing accommodations. But then our second highest is mental health. After that, 17% have an ADHD diagnosis, 11% have chronic conditions, 7% have a learning disability, 7% have a basic chronic medical condition, 5% have low vision, 1% orthopedic, 1% communication and speech, and 1% temporary disability. So we also work with students who might have a temporary disability, and that could be from things such as pregnancy to maybe a concussion. So those are types of things. But in terms of what have we been doing or action items, as we started out this presentation talking about the grant that is coming in through SUNY, we're really excited. Mr. Nicholas Cromie has come into our office, and he is our current Director of Accessibility Resources and Services. He's sitting there, so if you're a student and you needed something, hopefully you've had an opportunity to connect with him. So he is still currently onboarding. We also are really excited. We were able to invest in a software system, so we no longer have to use paper forms, and we're going to be launching that with our summer sessions. So going forward for summer and on, students will be able to go on, upload their medical documentation. We'll be able to work more seamlessly with faculty and staff once we approve those accommodations to send those out, and to annually review those with students to make sure that that's still accommodations that they need. So that's just kind of a snapshot of where we're at and where we're looking to go as we advance, and really happy to have that grant to support the work that we've already been doing.
Wonderful, thank you. And Dr. Dhaliwal?
Good afternoon, everybody. I am very thankful for all of you having me here and listening to me. I am an assistant professor at Physical Therapy Department in School of Health Professions here at Downstate. And I am a licensed practitioner as well. I'm a physical therapist, practicing for like more than a decade. I'm very sorry, I ran in a bit late. I had a very interesting class today, and very applicable to our topic. We were talking about principles of education, and we actually educate students how to communicate with their patients. And the first one we discussed today were our own personal biases, major barriers to treatment. So I'll be very brief about our curriculum. We have introduced a biopsychosocial curriculum into the practice in our PT curriculum, which basically means that we're not really just treating the disease per se, but we are also looking at other barriers that people with disabilities will face, social barriers, psychological barriers. I probably will beat the same drums like all of my co-workers and practitioners that are here. So really bringing an experience to students through lived experiences. I personally teach neuromuscular physical therapy, where we will teach people our students about spinal cord injury or people who may have stroke and Parkinson's, we actually have patients coming in who share their experiences to students and communicate with them the kind of barriers that they experience when they are home, you know. Nobody's keeping you in the hospital. Nobody's coming to you on an everyday basis. You know, it's an expensive business, like Dr. Huberman said. So we have to train the caregivers. We have to train our patients, and that's the model that we use in terms of lived experiences. And the second thing we also do is emphasizing like a universal design and accessibility. So teaching students that, you know, it's not just treating the diagnosis, it's also helping patients, you know, solve these problems, the barriers that they will have. So designing environments for them. If a patient post-stroke comes to you and that's the side of the handrail that they use, if they have a left-sided dysfunction, how will this person go up and down the stairs? That's where they lived. So we teach our students how to manage those things, create scenarios in class through a case-based, you know, learning, throw problems at them, and they come up with solutions and try to teach them to be as creative when they're out in practice. And then finally, you know, fostering that cultural competence. Our discussion today was about how Gen Z perceives, you know, things that maybe millennials and baby boomers think about disability, or, you know, how do they perceive disease? So there's a difference between generations. There's a difference between cultures. So really educating our students about being inclusive of all cultures, all genders, different generations that they will get to treat, because you're not just going to treat someone who's Gen Z or someone who's older. Disability doesn't see the face, it doesn't see the gender, and it doesn't see your age. So I think being inclusive, understanding representation of people who have disabilities, I think is one of the key things being taught in the curriculum. And I think in conclusion, all I would like to say is that along with physical therapy and all the different professions that are here on the table, I think they're all intertwined. I cannot be a success, and we teach students that, you know, it's not a one-person game. It's a team effort. You have to be a strong advocate for fighting for those teams and standing up for patients. And I think those are the key things that we at the Department of PT foster it in our students so that they go out and serve the communities the best way they can. Thank you.
Wonderful. Dr. Dhaliwal, I think you might find this interesting. It's reported that physical therapy educators such as yourself are witnessing an increase in the number of students with disabilities applying to entry-level programs, and those that are even requesting disability accommodations on the National Physical Therapy exam. And I see the same thing in OT, and I'm sure you know, with greater awareness and screening for services, I'm sure our other professional programs in health professions and in medicine are also seeing increases in the number of students with disabilities. So, you know, when you look at the barriers within the learning environment that exists for students seeking accommodations, be it in our programs or even for the licensing exam, a heavy burden is placed on the students and exam candidates during this process of applying for testing accommodations. So this question is open to the panel for those in education or in student affairs. How can faculty and staff be better trained to identify and proactively support students who may need accommodations, reducing the stigma and administrative burden that these students often face?
I'll probably take the lead, and some things that, you know, I do at my own personal level, Dr. Afkona, is that I do this thing when I first meet my students. It's called a little game. We do a profiling for them in terms of what color do they belong to, and what kind of learner are they? Are they a doer? Do they like to jump in and like be a participant for labs? Do they like to watch? Are they an introvert or an extrovert? that kind of opens up, and we do it in a very pure play fashion. I'm just there to kind of do an icebreaker for them, and they kind of participate. And I think it gives me an insight into which students might need more of my attention, and that becomes as a start-off point. And I bring it back to our faculty, and then from there on, we kind of observe our students throughout the program, and we definitely use a lot of services that are provided to us through Downstate, to the academic sessions. And then after discussing with our chair, we usually recommend, and students are very for it, because nobody wants to lag behind, and nobody wants to be like, I don't think so, I can't do it. So I personally think catching any kind of barriers that students have in terms of learning early on and being there for them, and they feel supported and they don't feel being judged. I think that's the first thing we like to do in like our program, and that's something that I like to do in my classes as well.
Thank you. Does anyone, Dr. Huberman?
If I could just follow, I'm thinking on several actually Len trainees who came through who were themselves with a neurodisability, ADHD, autism, who are medical students, and pointing out something that I had to take time. I'm thinking back to Bridget's presentation about invisible neurodisabilities and the tendency to say, you're doing fine, what's the problem? You have, and I'm thinking of students who to me were the most organized, doing really well, I admired them. But if you listen, talking about the cost, talking about what they go through, that they just need extra time, let's say, to process, or the effort that goes into having ADHD and yet still being on top of studies and what you have to do as a student and as an intern. So I think it comes down to listening and to being open and certainly examining our own, we think we're all enlightened, but examining our own biases.
I think that we've worked with the admissions office to make sure that there's information going out to all students, so it's not just letting certain students that we think maybe have a disability, but sending it to everyone. So sort of that universal design, as you spoke about. Everybody knows what the information is. I would say I think licensing groups are still struggling. If anybody follows the news, the Bar Association, they just ran into some trouble because they were making it extremely difficult for students to get those accommodations that they needed, which I think is fascinating all on its own. But, I do think it can be a challenge for students, and we try to work with students to give them as much advanced knowledge, particularly for those licensing exams, because though it might be very easy for you to provide those accommodations within your own classrooms, it's when they hit that next level for licensure that it gets really difficult.
Thank you. In clinical rotations for medicine, nursing, allied health, the stakes become even higher as students transition from the classroom, where we kind of have things in our own control, and they enter into real-world patient care. The technical standards and essential functions required in these settings often involve physical, cognitive, and emotional demands. And there's also this kind of idea of, don't rock the boat, right? Because we don't want to lose that placement. These all present unique challenges for students with disabilities. At the same time, the clinical environment offers an opportunity to model inclusion and create pathways for students to succeed while ensuring patient safety and quality care. This requires a thoughtful approach to accommodations in clinical rotations that balance competencies for students that they must demonstrate, but also providing equitable access to the learning environment. So, how do you suppose clinical educators, site preceptors can work to define and implement these reasonable accommodations during these clinical rotations? in a way that supports students with disabilities while also maintaining that standard of care?
Well, I will say, we often, as I said prior, we utilize the Job Accommodation Network, also known as JAN. And it's an amazing resource, and they provide, feedback and, best practices if a employee or even a student does need an accommodation. So if that does ever come up, you can contact us or you can reach out to Jen as well.
Right.
That's interesting, and even something I'm learning as a chair about the program, that although we have sort of an HR, employee relations, for licensed professionals, potentially we can tap you guys as a resource to help our students as well.
I'd like to add something. I think another aspect is to potentially demystify that clinical preceptors are not educators. Actually, they are educators. They're just as critical as academic educators, especially when it comes to allied health professionals. We have to somewhat empower, reinforce, and remind clinical preceptors that there is not only a professional but ethical obligation to nurture, to mentor, to empower, and to train students in not just what we call the academic way, but rather the competency model. In many of our professions, including PT, PA, OT, and so forth, the skill of doing is just as critical as the skill of remembering. Doing in the sense of understanding how to synthesize information, empowering students to remember that there is not much of a disconnect between what they learn in class to what they perform experientially in the clinic. There's a huge connection, and it often anchors the student to remember to self-advocate for their accommodations, for their needs, but also to understand the expectations of the clinical environment. So again, I think that we sometimes have to lessen the gap between the classroom and the clinical environment by allowing students to be themselves and to feel safe and not often criticized or belittled or judged based upon their needs. So I think that's one way to approach that.
Thank you. At this time, I would open up to the audience. If we have any audience members or even panelists who might have a question stewing, I welcome you to pose it to the group. Yes, please stand up. State your name with the microphone.
Hello, my name is Kristen O'Regan. I'm a second-year occupational therapy student here at Downstate, and I'm also one of the LEN trainees. I just wanted to start off by saying thank you to all the panelists and the speakers for your various perspectives and your thoughtful insights on this topic. However, I have one question to pose to the panelists, and it relates to the idea that most faculty are used to the standard extra time or having separate testing spaces as a form of accommodations. However, other accommodations can be viewed by some faculty as burdensome or as giving students an unfair advantage rather than just leveling the playing field and enabling success. This perspective can limit our ability to see accommodations as opportunities to empower students and enrich the learning environment with their unique perspectives and contributions. Perhaps the issue isn't that accommodations are too numerous or too difficult, but rather that our collective imagination hasn't yet expanded enough to envision truly inclusive and innovative ways to help all students. So the question I pose to you is that where do you think our imagination is not large enough when it comes to rethinking how we support students with disabilities? And how can we shift this narrative around accommodations from being seen as a challenge to being embraced as a way to foster growth, creativity, and the unique gifts that these students bring to all of our classrooms and professional programs?
Well said.
Great question. Very much.
I'll take a quick stab.
Sure.
I'll take a small part of that question. That was a great question, by the way, Kristen. So how about this? We, going back to Dr. Lewis and the presentations before that as well, disability and the idea of functioning, getting something done, but it doesn't have to be in the quote-unquote typical way. I thought about that when you were asking a question in regards to exams or assignments or due dates and so forth. And I think about the irony where we talk about being flexible, we talk about being sensitive, we talk about being cognizant and aware, yet our structures might seem or are so concrete that there is not much give on our expectations. And how ironic is that as facilitators and educators to be held to a standard where we can't meet? So I say this, I think one approach is to relook at the outcome of what is expected from students and to think about diverse ways to reach that outcome. As a quick thing, written assignments is one aspect. How about oral presentations? Practicums are another aspect of measuring competency. How about one-to-one skill assessments? Meaning, really, does our pedagogical or instructional approaches need to differ as opposed to our expectations? Should we teach more like in 2025 versus expecting our students to meet unattainable standards? Meaning, let's get contemporary with our educational approaches. I think that's a good start from my perspective.
Thank you. Anyone want to add to that?
I don't think so. I have any difference in opinion than Dr. Peck-Payton here. And your question was brilliant. And I think these thoughts occur to me personally. I'm a very new educator. I've been here only 2.5 years. I've been primarily a clinician. And when I compare the two standards, when a patient comes to you and if a patient wants to take time and they're not able to do something, the flexibility and the ability to, be able to give them more just seems very automatic. But when it comes to academia, the strictness, just like Dr. Peck-Payton said, that, this ability to have this concreteness around our structure and design is set forth in rules. And I think, personally speaking, I think there are personal biases too. Faculty has its own biases, and I think having more and more discussions like this one, where faculty actually comes up, and I will take this back with me and definitely bring it up with my faculty too. But I think personal biases do play a role, and you're correct. I think inclusivity is not just with, giving all this shout out about, we're doing this and doing that, and then it should be applicable to us too. So you've given us food for thought for sure. And I will definitely be taking it back to my department. Yeah.
Thank you. Yes, can we get a microphone?
A wonderful program. I'm Dr. Geary, short for Geary Dharan, pediatric neurologist here. And everything that each one of you, again, has shared means a lot to me. And I just want to say to all of you, I wish we had more Dr. Hubermans around. But, when you need, again, some of the medical background, since most of the different abilities start with the brain, as far as I'm concerned, that we in peds neurology, luckily I have several colleagues, we are here to help and to take care of the families, and they are a passion to me. Take care.
Thank you.
Can I just comment that when we have really difficult cases, I've often turned to Dr. Geary for how can we manage this one?
Sure.
That shouldn't be. We're talking about availability, accessibility, stigma, and everything. And again, it's very hard to get subspecialty appointments. And when Dr. Huberman says 350 patients a year, boils down to 30 a month. And peds neurology, we have several clinics. So please use us as the stepping stone to get to him. So don't reserve us as the last resort. because families need to understand what is the neurologic basis. And again, like you said, educators, we're all educators. And as a clinician, as a doctor, the meaning is an educator, teacher. So that's my primary role in teaching the families and patients what they have. And so they want to know what's wrong with them. Okay, so please, again, don't use us as last resort. Okay.
Thank you. I'd like to shift our attention to the employee side of disclosure. This is specifically for Zachary, but also others can chime in too. In your role, you may have dealt with a wide range of responses from supervisors and managers when an employee discloses a disability or requests an accommodation. And some of those managers respond really well, creating an immediate sense of trust and collaboration. And others, while technically correct, it might feel impersonal, like deferring to HR without first acknowledging the courage that it might have taken for that employee to speak up. And for me, I think there's such a critical human element in these moments where managers have the opportunity to foster trust and empathy and contribute to that culture of inclusion, even if they're unsure about what happens next. So, with that in mind, can you elaborate on the supports or guidance that's available for managers to help them respond more effectively in these situations where they can balance that human element with, the need for compliance?
So we're currently working on a training for all, for all employees on how to request an accommodation. We're also focusing on supervisory training as well. So we hope to have that rolled out this year. So I think it'd be important for everyone to be aware of the processes and the laws and requirements. And I always say to a supervisor, when you get some pushback, they don't want to grant a specific accommodation. Well, it doesn't have to be the specific accommodation that the employee is requesting, but that's part of the interactive process, right? We can't grant this. Well, what can we grant, right? We go back to the employee and we see if that's something that would work for them, and if everyone's in agreement, then we've successfully achieved that interactive process, and we can grant the accommodation. And I always say, an accommodation is not a privilege; it's a right under federal law, right? So, and state law as well. So if we are getting pushback from the supervisor or the department, you just have to remind them that it's not a privilege, it's their right, and it's something that we do have to, grant in some capacity. Again, as I stated earlier, unless it's an undue hardship, but that's such a high burden, especially for an institution this large, it just doesn't make sense as to why we wouldn't be able to grant some sort of accommodation, even though it's not what the employee is asking, but we can meet in the middle somewhere.
Sure. Thank you. Anyone want to respond or add to that? Any questions in the audience? Yes.
Hi, I'm Victoria Perez. I'm another second-year OT student. And just thinking as a student, disability competent care is an essential component of preparing future healthcare providers, educators, and other professionals to serve diverse populations effectively. Yet, research shows that disability bias remains pervasive, often rooted in myths, stereotypes, misunderstandings, or even a lack of exposure to individuals with disability. Today's students are tomorrow's clinicians. Provider biases can directly impact the quality of care for patients with disabilities, from dismissing concerns to underestimating their quality of life. This underscores the importance of integrating disability perspectives into the curriculum in an authentic way. With that being said, this is like a two-part question. Are there models of teaching disability in medical and allied health curricula that can be scaled in a way that helps a greater number of our student-challenged biases have empathy and refine their ability to provide equitable and person-centered care? And what strategies can educators use to ensure training is impactful and sustained beyond the classroom?
Wonderful, thank you.
Did you?
We have Dean Lewis.
There you go.
I'm sorry.
Thank you. Great question. You know, bias is a uniquely human phenomenon. We all have biases. And I have developed a 4-step process for developing, for a student identifying a bias or anybody, identifying a bias and addressing how to mitigate that bias. Whether it's a bias against disability or against race, ethnicity, or another dimension of culture. And the idea is you have to go through a constant process of introspection and self-awareness and asking yourself, what are my biases? And you got to pose all the various dimensions of diversity and culture that you can. And we know there are lots of them: race, ethnicity, sexual orientation, religion, spiritual orientation, socioeconomic status, political affiliation, disability, discipline, regional biases. There are many different types of regional cultures, local cultures, you know, the culture of being a New Yorker, the culture of being a person who lives in New York State. I'm not a New Yorker, so I'm
from Brooklyn.
Or from Brooklyn. So it requires an ongoing process of being vigilant to what your biases are. In the case of disability, you got to pose the question, what about disability bothers me? What about disability can contraindicate my ability to do my best work as an OT or a PT or a PA or health informaticist, whatever your discipline is. So this first step is to identify what that bias is and the nature of that bias. Second step is to think about, is this bias dangerous? In other words, if this bias raises its ugly head in the middle of a therapy session or me providing services, does it compromise my effectiveness? If the answer is yes, then you got to think about, okay, can this bias be changed? If it's no, no problem. If it's yes, then you got to think, okay, how can I modify this bias, or is it even modifiable? Because not all biases can change, because we're human beings. You know, when I was a clinician years ago working in public mental health, you know, there are certain types of people who would come in that I would say, I'm going to refer this person, because I don't like child molesters. And no matter how smart I am and how educated I am and how many years of experience I have, I just have a certain reaction to that population. It's not going to change. So to give them the best service they need somebody who doesn't have that bias like I do, because everybody deserves the care and services they need. So you identify whether you can change it. And if it's changeable, modifiable, then you go through whatever process is required to modify it. Sometimes it's more exposure to the disability culture. Sometimes it's reading more about it. If it's not going to change, you've got to come to grips with how you're going to, third step, how you're going to mitigate it, contain it. You need a containment plan so that it doesn't compromise your effectiveness. And the fourth step for all biases is to constantly scan yourself introspectively for biases going forward. Because as human beings, we all grow and change over time. So I may have a bias today that's not a bias 20 years from now, and vice versa. So you've got to be able to continually check yourself through self-reflection, introspection, asking these questions over and over again. I mean, there's no panacea, no silver bullet, because we're always human. But you can be conscious about it. The problem comes in when we go on autopilot and we don't realize, oh, this bias may be in the mix here and compromising my effectiveness. You got to know that you have the bias. You've got to identify whether you can change it, and if so, how you're going to do it. Not all biases can change. So that's one approach. Others?
So I like that the question that the OT student gave. I'm going to be on the next panel, but in preparation for that, I was looking for something that can be a solution, especially to the medical student, trainees and residents, and these are our future medical students and residents. And I came across a research article that actually had good outcome. And this was something that I think that it's an article. It's a research article titled Disability and Ableism in Medicine, a Curriculum for Medical Students. And it actually had good outcomes. And this was developed well, received 2-hour small group seminar for first-year medical students on disability and ableism. And through innovative and participatory activities, the sessions introduced students to a number of topics, including ableism, social model of disability, disability history and culture, and health disparities. And it really had good outcomes. I'd be happy to share that citation with the dean. But I think that it starts with our medical students training and residents for future. If there could be part of their curriculum, could be disability as a topic in their curriculum, and also speaking with people with lived experience, and that way they can be part of that curriculum as well. Thank you.
Yes.
Thank you, Mabel.
To follow up, absolutely. And I was inquiring colleagues at UCLA and other places, what are they doing about training a curriculum for medical students and residents? What I learned was, at a minimum, was show them the movie Crip Camp. And I had never seen it before. It's on Netflix. The idea, UCLA used some funds to both show it and have a pizza party that all the students could see it. That's where I first learned. I'm involved in 504 accommodations all the time. I didn't know the history of it at all. And Miss Human, who is featured in that. And it's just an incredibly striking history, very vivid. I didn't know 504 came about with people in wheelchairs blocking traffic. And I think that was, it just opened a perspective. So I think if we can look at ways to reach out, and it's a busy medical student curriculum, but if there are ways to introduce some aspects of that on top of what we're doing.
Go ahead.
I would also say, if you want to take a look, there's a ton of free resources. Docs with Disabilities. Dr. Lisa Meeks is really on the forefront of it and really talks about like challenges, kind of what we were talking about, what happens in the classroom and how we're not always accommodating, and ways that doctors have gone through programs, and really from there's some really amazing stuff there. The double AMC is actually putting out some stuff to help students who are going into residency of how to start those conversations, because not every office, educational office, employment office has those same. And so from templates of emails and how to start some of those conversations. So if you're curious, look at Docs with Disabilities. You can download some great resources there.
Wonderful. So in the interest of time, I want to close out this panel and give a little time to transition and break for the next panel. So I want to thank the panelists. Let's give them a hand, please. As well as the students in the office, in the audience, and everyone else here for contributing to such a rich conversation. And for those interested in learning more about disability, Dr. Lewis leads a virtual lecture series called Disability 101 for healthcare providers. And you can contact Dr. Lewis in his office for more information.
We have handouts at the table.
Yes.
It's a Dean's Lecture Series. This year's topic is disability.
Wonderful. So thank you, everyone, for such a rich and engaging panel, and I wish you all the best. See you.
Let's take a break for 15 minutes. This is going to be a great panel. The topic is Contemporary Perspectives on Disability. And we have four experts here. They can give their long introductions, but I'll give a brief introduction for each one. Dr. John O'Neill, to my immediate left, is director of the Kessler Foundation, which does a lot of research on disability out in New Jersey. And he and I worked a little bit together on a common project with Dr. Corey Moore at the Rehab Research and Training Center out of Langston University in Oklahoma City. And Dr. Suzanne Briere, his left, noted expert in disability from Cornell University, and she'll tell you about her institute that she represents. Dr. Briere represents a generation of disability educators that gave birth to me. So she she and I know some of the same people. She knows my main mentor in disability, and they were cronies. So I, always give a lot of deference to Dr. Briere. Uh, building my career on the shoulders of hers and other colleagues like hers. And then we have Dr. Shoshana De Oliveira, Dr. Shoshana De Oliveira, who is our Associate Dean for Program Operations and Quality in the School of Health Professions, but she's also a family member of a person with a significant disability. She's going to give that family member perspective. And the panelists can give more introduction, as you go. And then we have Mabel Martinez Amante, right, who used to work at Downstate, used to be on our OT Community Advisory Board. Mabel is a person with a disability, is also a professional, has had a long career in healthcare and as well as disability, and she can give you more details. So we have an expert panel, two renowned disability educators and researchers, a family member, and a person with a disability. So I'm going to yield the floor and let them kind of tell you their contemporary perspective on disability. And normally I do ladies first, but since we have the PowerPoint, Dr. O'Neill, would you go first?
Sure.
Okay, let me see if I can pull it up on the big screen.
I'm going to take us on a little journey today related to some recent research, combining two elements of some recent research that we're doing at the Kessler Foundation in collaboration with the University of New Hampshire. And, okay, thank you. And I will be...
You can actually advance it for you if you want to do it, you can do it.
Sure.
Will you do it
Thanks.
for you? Okay.
You can do it. This is some research that's going to take us on a journey looking at employment among people with disabilities from 2008 to 2025. We can only do research in terms of employment during that period because it was only in 2008 that the Bureau of Labor Statistics and added 5 questions to their current population survey, which is the survey that is done on a monthly basis looking at employment. The 6 disability questions were related to hearing, and there was one on vision. There was a difficulty in terms of concentrating, remembering, etc., making decisions. There was a question on walking, climbing stairs, etc. A question on difficulty with dressing or bathing, self-care essentially, and difficulty going on errands or outside the house. So these 5 questions allowed the current population survey to actually be taking a look at employment. Next slide.
Are we seeing the whole thing?
Okay. Thank you. Now, the slide you're seeing before you is complicated, but it basically tracks the employment of people with disabilities and without disabilities from 2008 on. The top graph is a graph showing the employment of people with disabilities on a monthly basis, starting in 2008 through 2025. And the lower graph, which is on a different scale because it's the employment of people with disabilities during that same time period, but the employment rate is obviously much lower. If we look at this across time, 2008 was the beginning of the Great Recession. And people with and without disabilities were losing their jobs at a great rate. People without disabilities, they're at the end of the Great Recession for them happened in June 2010, only 2 years after the 6 questions were added to the survey. People with disabilities, they bottomed out in 2014. So that's a number of years after people without disabilities bottomed out and before they started to improve. And people with disabilities bottomed out at an employment rate of about 24%. People without disabilities bottomed out at about 69%. And then we're looking at how people recovered from the Great Recession. And we see that it was a steady incline for people without disabilities. And there was kind of a jagged, but definitely trajectory upward until COVID hit. And that gray line kind of to the left is when COVID hit and the employment rate for people without disabilities plummeted from about 75% to 63%. For those with disabilities, it plummeted from about 32% to 26%. There was a recovery. Obviously, you can see it from the trajectory there for both groups. What's most important here in this particular graph is the trajectory for people with disabilities. Not only did they reach their pre-pandemic level fairly quickly, but in 2000, little before the beginning of 2022, they had outstripped their historical highs. And they continued to increase in terms of their employment to population ratio until about the end of 2023, and from then on until just last month, they have sort of plateaued. I'm going to present some additional data right now on two surveys that we did looking at the COVID pandemic and disability employment. And this again was, one survey was in 2017, the other in 2020, just as we were beginning to merge from the COVID pandemic. And so we have, these were both surveys of supervisors. One was about 6,000 supervisors nationally, and the other was about 4,000. And we were able to compare supervisors' perspectives around employing people with disabilities in 2017, which was before the pandemic, obviously. Just as people were emerging from the people with disabilities were beginning to merge and get close to their historical highs. We asked supervisors about best practices for recruiting, hiring, and onboarding people with disabilities. And that was in both surveys. In 2022, we also asked about the impact of COVID on businesses. Otherwise, the surveys were identical. By comparing the employer use of best practices pre-COVID to practices post-COVID, I think we can gain some insights into why there were increases in the employment of people with disabilities post-COVID, such that the improvements were so great that they had reached above their historical highs. Not to say that those historical highs are acceptable, but they were historical highs for people with disabilities. In the findings from the 2022 post-COVID survey, we found that 38% of the supervisors reported moderate to large decreases in the number of employees. In other words, we all heard about the Great Resignation, right? And that's what happened after the COVID pandemic for people with and without disabilities. And that gap for employers could have driven employers, and very well might have, to be more open in terms of how they recruited people for new jobs, and they may have been more flexible. And some of the data from 2022 suggests that. Also, 47% of the supervisors reported a moderate to large increase in the percent of paid employees working from home. Another indication that employers may have been becoming more reasonable and flexible in terms of providing accommodations, particularly for people with disabilities who might have transportation challenges. 69% expected that this change increase to increase over the years in terms of people working from home. 78% of the supervisors reported that their organization used established or changed their accommodation processes due to issues created by COVID. So suddenly they had a number of employees who were coming down with COVID. They knew those employees. They wanted to keep them. So they modified or improved their accommodation processes. Or another finding was 76% of the supervisors who worked in organizations with established accommodation processes stated that their organization used those processes when they were requested by individuals with COVID. We also compared best disability employment practices in 2017 to 2022. And these employment practices are basically considered to be best practices. And one is to partner with disability organizations when you're recruiting for people with disabilities. And in 2017, it was 27%. In 2022, it was 43%, a big increase. Training supervisors in accessible application and interview techniques increased from 40% to 58% after COVID. Auditing hiring procedures, that is the companies keeping themselves up to speed in terms of how well they're doing in terms of hiring people with disabilities, increased from 43% to 53%. Employees using short-term outside assistance, that may be job coaching or some sort of consultation regarding accommodations, increased from 19% to 32%. Comparing again, and I was talking to our colleagues here in HR about the centralized accommodation fund that's considered to be a good practice. It increased from 16% to 39%. Flexible work schedule increased from 25% to 40%. Flexible work schedules, being able to go see your doc during the day if you can't get an appointment at night. Working from home increased from 18% to 42%. Job sharing, which is also another kind of accommodation, increased from 13 to 36%. And training employees about disability culture and etiquette competence increased from 43 to 58%. So I think the story here is, I believe this is indirect evidence that COVID increased the flexibility and the interest in employers in terms of hiring people with disabilities. And as a result, at least to some degree, the employment rate of people with disabilities jumped quickly and to historical highs after the pandemic. We certainly don't want any more pandemics in order to increase the employment of people with disabilities. But I'm thinking back to World War II, where the employment rate, at least as the common lore goes, the employment rate was for people with disabilities was the highest it had ever been and ever had been since. That's the folklore, at least. There was no data at that point in time. So crises can have a silver lining sometimes. That's basically it. Yes. Yep.
Sure. Well, thank you for the invitation, Dean Lewis. I'm delighted to be here and to reconnect with my colleague, John O'Neill, and to meet new colleagues. It's a privilege to be here. I'm going to first kind of talk big picture of what I'm doing and how I got into the disability area, and then really hit very big picture what I think are the focus areas for that are currently emerging as I view them and what I perceive for the future, and kind of how I think we can all work on it together in the short 10 minutes I have with you. First of all, I'm in the School of Industrial and Labor Relations at Cornell University in Ithaca, on the Ithaca campus. And that's a perfect place for me because it's a college for the workplace. And my focus has been employment. And I got here in that at age 16. I started in disability at age 16. My first job, other than babysitting, was as a psychiatric attendant in a state residential facility in St. Lawrence County in upstate New York, in Ogdensburg, New York, which was quite a place for a 16-year-old to get acculturation to disability. Also the year that my youngest brother, who's a person with Down syndrome, was born. So that started my interest. I started out in special education and psychology. And each choice after that was really because I felt I needed to do something different to be more effective to impact people. I didn't feel like I had enough influence in the classroom. And I went into vocational rehabilitation because I thought counseling might be helpful and that employment seemed like it would be an important thing to focus on. And from there felt that systems were troubled, so that maybe if I got into employment policy, public policy, I would have more influence on the systems that serve people. And in the last, probably, I think, since the passage of the ADA, I focused more on workplaces and private sector. So that's why the ILR school has been a good home for me. So it's been an evolution, and that continues to be. We talked a little bit, our colleagues, Dean Lewis and John also has traced some history. How we perceive disability has changed over the last 100 years. This disability as an interest, as a movement, really evolved legislatively after World War I with a focus on returning veterans. And over that 100 years, we in the 60s began to look at intellectual disability, developmental disability, mental health came on the radar. And now, as Dr. O'Neill mentioned, long COVID, who would have ever thought that would be a focus, and it definitely is, and neurodiversity, as several of our colleagues in the previous panel, high profile in the disability area, and a place that I've been focusing some of my own energy as a rehabilitation, I don't know if I said, I'm a rehabilitation counseling psychologist, as well as a special educator and a certified rehabilitation counselor. Those are the disciplinary areas that I come from. So what we perceive to be included in the disability tent has changed. Some of our colleagues talked about Dean Lewis, about the shift from a medical model to a social model, and a recognition that environments, how we create physical spaces, makes a big difference in terms of whether people have barriers, whether their impairments actually present barriers. So looking at how we create environments, and the social model has been a big shift for us. And that's reflected in the ICF and a recognition that one of our indices of efficacy of whether or not our services are being effective in our communities are contributing to inclusion is participation for people with disabilities. There are so many things we could talk about in terms of inclusion: housing, transportation, voting rights. I've always focused on employment, so I'm going to continue to have that dialogue. And mostly I have focused on workplace inclusion because it seemed, even though we worked hard to prepare people to get jobs, there was a barrier in actually getting employers to do the uptake of these individuals. Although we have had surges, as Dr. O'Neill has indicated, there have been times it's been more advantageous. Often people are in lower jobs, part-time jobs. They benefited during COVID, I think, because many were frontline workers in essential positions and were needed in the workplace and able to stay there. Some of the things I have seen in the last 5 to 10 years that I think are areas I will say, here are the emerging areas, here's the contemporary focus, is a recognition about the importance of intersectional identity and disability. We know that gender, race, ethnicity, and now LGBTQ plus status also plays into how equitable people are able to participate in the workforce, the compensation that they get, whether they are linked more to seasonal jobs or part-time work. So looking at intersectional identity is now reflected in the data, like that Dr. O'Neill had talked about, but we also see it how it plays out in the workplace. So intersectional identity, very important. AI, all of our disciplines are talking about the impact of AI, and that is no less true in workplaces. Algorithmic screening is a huge area of concern. It's both a boon for companies because they can sort through much more effectively hundreds, if not thousands, of resumes that they get for jobs, but it means they are leaving a lot of talent on the table for non-traditional employees. Often that includes people with disabilities. AI is also a boon to many individuals. People with neurological impairments find these tools extraordinarily, and I'm sure our students, you see your students using them to be able to navigate some of the tasks they need to do, but it is also something for our attention in terms of inadvertent discrimination. Dr. O'Neill mentioned, how workplaces have changed, and indeed, the pandemic moved us along for recognizing how we can be flexible in flex place, in remote work, and give people an opportunity to participate in the workplace. That's been very helpful. Many more independent contractor-related opportunities, but along with that is an attendant dissociation from equity sometimes in career advancement if you're doing that within a large company, and consideration for other opportunities in that workplace. So something to take a look at, that changing nature of work. One of the areas that I work in now, I've been working in for 10 or 12 years, and we have a National Science Foundation grant on workplace equity for people with disabilities, is a focus on neurodiversity. Specifically, we've been looking at autism and how companies who have taken an ardent interest in this area are very proactively making changes in their workplace to try to really affirmatively recruit autistic individuals into their workplaces. The question that the student asked about innovation and creativity is an excellent question. I think we tend to be more limited. I'll speak of my own university, within universities, within state, federal government settings than I see in the private sector. What I've observed in the last 10 years is extraordinary innovation in companies who ardently were seeking autistic individuals for mostly STEM careers originally, really trying to bring that talent in and dramatically changing how they did recruitment, how they did interviewing, how they did some of the innovative ideas discussed by our prior panel, allowing demonstrations, giving the job interview questions to people who are going to either be conducting the interviews or preparing people to take the interviews. So a lot of innovation occurring in the private sector that I think we could all learn from vis-a-vis helping people with disabilities to get into the workplace and stay there and thrive. Changes in how workplaces themselves are constructed, not just the virtual environment, but within work environments, open spaces, that dramatically can affect people with disabilities. And I've been humbled and interested in looking at how environmental psychologists are beginning to use disability as a way to make the point about the importance of light, space, noise considerations for all of us, using people with disabilities, neurological impairments as the litmus for what will work for everybody. I think that innovation gives us an opportunity to infuse into other disciplinary areas the perspective of people with disabilities that is really so critically important. So big picture issue, I think I'm doing okay on time, but I'm probably, mental health is huge. It was referenced in our prior panel. It's huge in society as an issue. We see it as probably the number one thing that employers are talking about and concerned about right now. We rub up against it, as some of our colleagues mentioned, around neurodiversity, working with autistic individuals in the workplace. There seems to be many comorbid conditions. And so preparing workplaces to have an EAP that really can serve neurodivergent individuals, that is more innovative in its approach. These are things that are absolutely necessary and will benefit all of us over time. But mental health, big consideration. Impact of natural disasters on people with disabilities. They are disproportionately impacted. Employers are concerned about it, thinking about it in emergency planning, but we need even more of that. Threats like the pandemic, close to home, but also global in their influence. So multinationals are thinking about that, as well as natural disasters and conflict. We have significant issues of conflict in so many parts of the world today. Not only have many lives been lost, but many people left with disabilities, and countries will be struggling to try to figure out how to put systems in place that respond. So I think that flags the importance of conversations like this, of forums like this. And I think what I saw in the prior panel is really symptomatic of what is needed, and that is it needs to be a transdisciplinary lens, that we bring our best thinking from all of our respective skill sets and knowledge bases to apply to these problems that are local, they're regional, they're national, and now they are global. We are all tied together. So I appreciate again the opportunity, Dean Lewis, to be here. Thank you. And that is what I see with the emerging issues that I think we should be keeping in dialogue. Thank you.
Thank you very much. Thank you very much. You've identified a lot of things that I'm sure people haven't even thought about. So we're going to keep going. We'll open the floor once we hear from our next two presenters. Dr. De Oliveira, family member.
Hi, everyone.
Person with disability.
Can you guys in the back hear me? I tend not to project very well. So I'm going to share a personal story. Bring the mic closer. Okay. I'm going to share a personal story. And for those who have known me over the years, may not be aware. And it took a lot of courage. And Dean Lewis, I thank you for the opportunity. And I thought it gave me, Dr. Lewis's invite gave me a cause to pause, right? Because as parents, we tend not to stop and think about what we're doing or what we need to do for our children. And it made me reflect. So I thought about, if my son were physically present, what would he try to convey to you so that you get an idea of what his day looks like. So I just wrote a little paragraph that I'm going to read. Imagine not having control over your body. You're unable to move, unable to speak, unable to see, unable to hear, and you rely on someone to take care of your everyday need. Your body seizes daily, your heart rate drops, and you struggle to breathe while you're trying to grasp your breath. You're dealing with this discomfort, and you're drenched in sweat, and you're gagging on your own saliva. You rely on a gastric tube for nutrition, and if not attended to daily, hourly, every minute, you struggle to recover and you face the possibility of dying. That is the reality of my son, Brian. He was born with, due to lack of oxygen, he was diagnosed with cerebral palsy. And when he was born, the doctors did not think that he would live past a year. He's now 32, and he's alive and kicking. He's in good health, considering his condition. As parents, we struggle with navigating the insurance companies who every 18 months, they reduce hours. We started with 24 hours, got reduced to 16, and we have to supplement those hours out of pocket. And every 18 months, when they go through their renewal, they decline service because they said his outlook is not improving. Therefore, it's not necessary. He's not benefiting from the services. And we have to go through an appeals process. And sometimes we only receive maybe a month or two notice that hours are going to cut. We're both working parents, and we rely heavily on home care so that we're able to provide, resulting in schedule shift, right? One parent works in the day, which myself, husband works at night. If a nursing coverage is not available, we have to pick up the slack to make sure that he has the care that he needs overnight. Quality of home care is not the best, so you also have to keep an eye on the very person that you're hiring to care for your son. Basic necessity in terms of skin breakdown, routinely changing and turning to make sure bed sores don't occur. And there's a lot that I'm forgetting because it's all coming through. We also navigate transporting him to and from his healthcare team, which consists of about 7 doctors, sometimes more, depending on what's happening to him. So only to arrive at the doctor's office for the doctor to spend less than 5 minutes with him. And it's really just a conversation between you and that doctor. The doctor is not physically touching him. We have advocated for telehealth or telephone conversation because he has home care, right? So they take his vitals every day, and they're able to report or review the progress notes that we have on file for him. But I guess it's a copay thing, right? When you bring your child in, you have to pay that copay, spend 5 minutes, and you're on your way. We have attempted to coordinate services where we'll take one day to take him to all his doctors. That does not always work out. And I'll step back a second. When Brian was growing up, he was able to eat orally. However, the older he got, the fewer services he had, right? He kind of aged out of the system. So with that, he was not able to continue with the swallow testing and things that he needed to continue to maintain that range of motion, which then resulted in him having a gastric tube inserted. The downfall to having the gastric tube is that it gets dislodged, right? So he was in school, but because of the lack of care, it would get dislodged, which end results him having to go to the hospital to have it reinserted. So as a parent, we had to learn quickly how to reinsert the tube ourselves, because when he goes to the hospital, he's at risk for further infection, right? So we try very hard not to take him to the hospital or a doctor's office. So that's really the day-to-day things that we have to deal with. More importantly, it's the nursing care that the reduction of hours is what we battle with on a day-to-day basis. And the types of individuals that are pursuing home care, right? A lot of them will come in and they'll go to sleep, leaving him unattended. If he's unattended, he could aspirate, which will put him back in the hospital. So there's a lot happening. It's very complicated, but you don't, as a parent, I don't stop to look at the individual things that we're dealing with. It's more about how do we protect him, because he can't do it for himself. He doesn't have a voice. So I find that when it comes to physicians and nurses who aren't caring for him or brushing him off, I think Dr. Desport mentioned earlier about being pitied. I hate that. I hate when people look at him. And the doctors aren't being trained to be empathetic or to coordinate services. Harris's model stood out to me and I laughed. It's a good model, the hub model, because in reality, if it exists, it will be ideal. But the older he got, he aged out of services and we were left to fend for ourselves, to find services for him. He used to get OT and PT, speech, all went out the window, right? You have to pay out of pocket for these sort of things because the doctors or the therapists won't come in home, right? So it creates this inequality and imbalance for him. And I'm gonna leave it there.
Very moving, Shoshana. You're a superhero.
Don't do that.
Go ahead, Mabel.
Sure. Hi, I'm Mabel. I'm a graduate of Downstate here in the OT program in 92, an employee here from 93 until just November of last year. And as a person with a disability and also an occupational therapist, I have a unique perspective of living in two worlds. So I view my disability as a gift in developing self-advocacy. And that's one of the things that I think that I would highlight because my first disability was an acquired disability. So I'm glad that Dean Lewis had actually explained the differences. So I acquired my first disability at age 25, but then I had a work-related injury and I acquired another disability on top of that. So when I think of the contemporary view of disability and as an individual having to cope with this, I can only recall these past, I would say, 6.5 years after a work-related injury and a busy schedule of seeing different medical providers. But I faced physical barriers and attitudinal barriers because I remember many scheduled appointments. And if on record I was somebody who was a wheelchair user, I was being given an appointment, and upon arriving at that appointment, there are steps. So there's no wheelchair access. Then either driving all the way to the city, going to a doctor's location, and again, steps. And you're left outside. There was no waiting area outside, and it's raining or it's snowing. And so what that just taught me was how do I become a better self-advocate and call ahead, find out all the details and aspects ahead of what is expected. And then also, since I have been home, I've been taking advantage of doing a lot of webinars and self-training and professional development. So I find that to be a plus. And one of the things that I came across, believe it or not, but this came out in 2017, but it's a model that's called the 4 M's of age-friendly care. And I said, well, why does this only have to be for geriatric care? Why not apply it to myself? And so I said, okay, so with every doctor visit that I go to, I look at, okay, do they ask me what matters to me? Do they ask me about all these medications? Because on top of whatever medication I was taking for myself for the first acquired disability, I had to take other medications just to cope with the pain. And then mentation. When you have a disability, mental health is a crucial aspect and a key component of how does that affect you now having maybe not being able to do some of the things that I was able to do with my first acquired disability. There were things that I was not able to do, but thank God for my husband, who's now my full-time caretaker. But I mean, he has learned to cope with me in my first acquired disability and now having to have a second disability or inability to do things. And then mobility. I find that even as an employee, having been an employee here, there were a lot of areas that were not wheelchair accessible. So when I think about the panel that was here earlier, I'm glad that there are different things taking place especially Zachary, when you spoke. I wish that there were more opportunities when I was an employee to have taken advantage of those services, because I was given an opportunity to come back to work and just to do sedentary work. Well, guess what? I was told that I would be a liability to come back. And so I would either have to be given a state, how do you call it, medical review or whatever. So I didn't come back. So I remained home. So, okay, so if I can remain home, how more education? So that's what I've been occupying my time with. And I'm glad because I've been able to do volunteer work and specifically with nonprofit agencies that work with people with disabilities, autism, and IDD. And so I've been able to use my occupational skills as a consultant and work and give my services there. And then I've also been thankfully sponsored by the nonprofit organization to acquire more training. So I'll be doing teen mental health first aid, which I'm already certified as an adult mental health first aid instructor and youth mental health first aid instructor. But this organization, this nonprofit organization, services a lot of youth and people with disabilities. And so this is my opportunity to give back to the community. So in a way, that's why when I say that I find my disability as a gift is because although I may not physically be able to do a lot of things, but my brain is still not dead. And I can acquire a lot of knowledge and then share it and provide services elsewhere. So one of the things that I am thinking about was I heard Margaret Kaplan on the website, the Downstate website. They have these different videos. And so I was looking at one of the videos last night and Margaret Kaplan was addressing something and she was speaking personally about one of her parents had a, I'm not sure if it was a stroke or something, but she talked about the assumption and the question she said about engagement. So with every medical appointment that I go to, I want to see where the engagement is because a medical provider may not know how to address you, especially if you have a disability. But we can work together. It's okay to make mistakes. So I tell the doctor now, how can we best work together and make this work, whatever that need is that I came to you for. And so I really feel that this disability, this second disability, or the issues that I'm having have really empowered me to be able to advocate. And now I teach those self-advocacy skills to others. And so I say to people, it's okay when you're going to go to a doctor's appointment and maybe, it's not working out the way you expected it. But then you tell this doctor or this provider, you're the president of your body, you know your body more, and so you're okay to advocate for yourself. And then they just need to be able to hear that, be empathic, and understand. You could say no to treatment, you could say yes to treatment, and you can give the reason why. So that's it.
Okay. Wow. Wow, very powerful panel. I'm going to make one observation and then open it up for questions and comments and observations of others. So across these four very different presentations on contemporary perspectives on disability, I heard about emerging disabilities, long COVID being one of those, also intersectional identity development with disability, no empathy from providers, lack of engagement by providers, and the need for self-advocacy. So given those themes that I've picked out of what's been said here, one thing that occurs to me that might be needed, and we know that in the disability world, we're always promoting more empowerment and self-determination. So the question to the panel is, given those themes, no empathy, lack of engagement, self-advocacy needs to be stronger, these emerging disabilities, at least two types, how can we, as a community, providers, persons with disabilities, the entire community, advocate for empowerment and self-determination, taking a more center stage for people who have disabilities. And empowerment meaning really being able to articulate what's best for you. Same thing with self-determination, really determining the destiny or the destination that you're seeking in terms of the outcome of services. Two big principles in the disability movement that we're still struggling to actually manifest. So panelists, what are your ideas on how we can do better with empowerment and self-determination of persons with disabilities? Because that's one way that people who have a disability can really hold a system accountable. Because that advocacy that Mabel talked about really comes to life when you have empowerment and self-determination as a person. Go ahead, Dr. Briere.
Happy to jump in with a few ideas. You know, I know medical settings have had patient advocacy groups or advisory groups. I think that has been, it depends on, how effective they are, but an example. And in research, we've been talking for over 30 years now about participatory action research. And I think as we conduct research, we really need to think, is the heart of the problem as we're defining it, is it the voice of the people that we're really targeting and serving? We're attempting to do that in this research I mentioned with the NSF project, in that we have a cohort of people we're calling community researchers who are autistic individuals with these intersectional identities, and they are helping us to refine the problem, to develop the protocols for the research. I mean, that's one example. I think each of us in what we're doing, really integrating that voice as a part of how we're defining the need, delivering the services, evaluating the services, is how to bring that empowerment into a real change of the processes that we're involved in. My initial thought.
Good point.
I was thinking earlier, it was mentioned that Dr. Sable in the occupational therapy program has the students either become familiar with the equipment that either the adult or the client is going to be using, so familiarizing themselves. But I was just thinking, even through case vignettes, in every discipline, School of Nursing, public health, occupational physical therapy, I think that if they actually can not just talk about the disabilities, but also role play, but having just real people with disabilities in an actual class and say, what would it look like for you're standing, you have a client before you, and so they just need to advocate for themselves. Have the students role play that advocacy thing, and you have the person with the disability can say, and give their viewpoint as well. But I just think that that is just something more experiential that I think that can take place and kind of have a shift.
Right. Okay.
What comes to mind, or what came to mind when you asked the question, is the simple act of listening.
Good.
And I think for me, it starts in our school, right? Us training people to go out to serve. Through my experience, the doctors are just doctoring. They're not taking the time out to hear from the family and from the patient. They're more so putting into practice what they're taught. And that has been my biggest frustration. You're not hearing.
Right. Okay. Well, go ahead, Dr. O'Neill. Are you going to say something? Were you going to speak, Dr. O'Neill?
Yes,
Okay,
I'm
go ahead.
going to say what impressed me about your presentation of your son's history and your own experience with that was a kind of discontinuity between the services that were available when your son was younger and how they're not available
Right.
later in life. That's a real gap, particularly for individuals with such severe conditions and great need. Yeah.
Okay.
Advocating for that as a community, we should be doing.
Well, I know Dr. Huberman and I talk a lot about systems change on the Lynn grant for persons who are neurodiverse. And then I'm reminded of the quote from Frederick Douglass that says, "Power concedes nothing without demand." So we got to make sure that that demand is there. So with that, let's open the floor for any questions, comments, critiques, observations to anybody who's here for this panel and about anything that's been said today. I know this morning we had a couple of presentations that you didn't get a chance to ask questions about. So the floor is open.
Dr. De Oliveira, I thank you for your most eloquently put of how to teach people to advocate for themselves. I think we need more teaching of that. Usually, again, I teach my families and parents that, again, when they go into this relatively hostile environment of the doctor's office, of saying a little, instead of getting frustrated and angry, just lose a little honey because we catch a lot more flies. And so I tell them, so in your sweetest voice, ask and put them at ease. Many of the times they feel their back is against the wall. Luckily, being an experienced physician and a patient now, I understand every little smile goes a long way. So I just wish we could teach what you're, doing to every person, medical and otherwise, to say how to approach a situation. So that's my thank you to you and to the mother who, again, it means a lot when we are faced with it every day and want just, respect, okay? Not sympathy and pity. And I thank you both also for the wonderful information that you've shared on our personal journeys.
Got question over here, comment?
Thank you everyone for sharing. I listened to the first panel online before I came. Missed one of the presentations because of class, but so I'm currently a LEND trainee that Dr. Huberman mentioned as a self-advocate. I'm neurodivergent, like ADHD, if anyone's heard that term, ADD plus ASD. And I have a lot of other health issues too. One thing I wanted to bring up about the listening aspect with doctors is the system forces doctors to see patients in an insanely short period of time that does not allow us to do the things that need to be done. I recently had a new patient visit that ended up being an hour, and that particular provider is like notorious for going overtime. So like every 5 minutes, someone was knocking on the door to like, okay, like you have to leave now. And I was like, didn't want to hold her up, but it's like, that's the way things should be. But like insurance policies and all those things. And like, I don't know, I just hope that she doesn't get in trouble as an employee for doing that. Someone mentioned environmental issues. I hate fluorescent lights. LED lights also oscillate. Sometimes they trigger like inappropriate brain activity in some people. So it's like, how do you find something that works for one person and also the other person? And then, I don't know, we go back to like halogen bulbs or whatever, except those are supposed to not be good for the environment and whatnot. So that, I don't know if someone's going to invent some kind of light bulb that just solves all those problems. But sorry, I had a lot of thoughts earlier. I wish I had been here.
Go right ahead.
So we were talking about institutional accessibility in education. Accessibility is not accessible, even if you know that you have a disability or something that needs to be accommodated. Evaluations for that cost thousands of dollars. You have to find someone, you have to convince the people that you meet these criteria to get these accommodations. It's a huge burden on like any student who has to go through this, especially if they have executive functioning issues, which makes filling out all the paperwork and getting appointments extremely hard. And then one thing I told Dr. Huberman about in the past is like, the ADHD is not the thing that hurts me the most when I'm taking tests. It's more of things related to autism and some of my other issues, but the school does not accept ASD as an accommodatable, I don't know if that's a word, disability for getting testing accommodations. They only accept the ADHD part, even though that's not really like the worst in quotes. So there's this disconnect between like, oh yeah, we're talking about all these disabled patients, this like life, I don't remember, like life course care clinic, whatever, like life, how that's actually integrated into education and workplaces. Like the concepts getting lost in between identifying people and actually being able to apply accommodations to them. For my capstone project, you mentioned empathy. I'm working on something that's basically a questionnaire to get, it could be medical providers, other healthcare providers, even people who just work at a medical office, to kind of go through cognitive biases that they might have. Because some ableism is really just cognitive biases, not like intentionally hating people for having a disability. Like if someone is bad at something, do you assume they're bad at other things? If someone is good at something, do you assume they're good at other things? Like, is it possible that if you're having trouble with a patient, there's a reason you're not seeing? Like just getting people to think about stuff. I think it would be great if somehow I could get that added to some of our classes, but that might be a little ambitious. And sorry, I'll try to wrap that up. Someone mentioned ASL too. There's a upper class student, Joya, I think, who had been trying to get an ASL elective started here. I'm actually talking to her next week because I think that would be really great to have. There's a big deaf community in New York, and remote translating options are really not great. And one thing I've always heard from people in the deaf community is like, okay, so you say, oh yeah, I wish I had learned ASL, so why don't you? So I would really like to see that here. And again, I feel like it might be a little ambitious, but we'll see if I can be part of making that happen. Thank you everyone for sharing your experiences.
Thank you. Thank you, Sylvie. Sylvie's a medical student here downstate as well. So, anybody else have a comment? You know, Sylvie, we may have to start a disability program in the School of Health Professions, which would be right up my alley, of course.
Help me in.
Dr. Desport?
Thank you. I think it's worth repeating what I talked about earlier, and that's really intervening with those external and contextual factors that I think we constantly don't think about. They're not part of the equation. We keep looking at the person, we keep looking at the individual, that somehow they need to change, they need to fit, they need to somehow accommodate to the world that we typically live in, versus saying, why don't we make some systemic changes, really come together and think big picture and put our brains together and make systemic, concrete changes that are so doable. But it's just that we're stuck in what's comfortable for us, because as Judy Newman was saying, you know, this disability thing that people, you know, experience, it's something that feels sort of threatening to them, meaning us, the able-bodied people. And if we're really thinking beyond the present and really honest, it's not a matter of if, it's a matter of when. Each one of us will be disabled at some point in our lives. So, as she was saying, again, Judy Newman, building, thinking for everybody, not just for the disabled person, but if there is that time in your life where you might need a housing situation or some kind, or your environment to be constructed in a way to accommodate you, it's being proactive, it's being anticipatory, and it's not being reactive once we're in the situation. And thank you for sharing your story. I know that must not have been easy. So I know it wasn't easy. So I just want to say thank you. That was important to hear.
Any other final comments or questions? Anyone?
Hi, I'm Stephanie from Labor Relations. I think the idea of having guests visit classes that are disabled or experience disability is a great one. I have a friend of mine who's wheelchair bound. She's been her entire life due to a degenerative disease. And, there are things I feel like people who don't have a disability don't even consider that you could really benefit from just having conversations with people who are disabled. She's an advocate for like increased transportation options for disabled people. One of the things she really works on is working with like the MTA for like making more accessible stations. So there was a project that she helped work on where how long does it take someone who's disabled to get from point A to point B, and things that you think, oh, I have to come to SUNY Downstate. So for example, I'll just get on my stop and get off at Winthrop. But she has to think about where is the nearest stop with a wheelchair, with a elevator, and then not just where is the nearest stop with an elevator, but which is the nearest stop with an elevator that works. Yeah. So, there are just little things that people don't think about if you don't have to think about them, that I think if you're going into the medical field, you would benefit from just having a one-on-one interaction with someone, especially if you're going into a field to deal with a certain population. You should definitely speak to people with that affliction. Yeah, that's it.
Okay, thank you. Stephanie. Anybody else? Okay, Doc.
Oh, one.
We'll try, unless there's another burning, we'll probably conclude at this point.
So I'm in the College of Medicine. I'm a neurologist, Yakov and Ziska, and I treat both kids and adults with disabilities. But what I find is, as an associate program director, my residents have no idea about disabilities. And I would say, just like we were saying before, even in the College of Medicine, right, there's no formal teaching for disabilities. On the other hand, for occupational therapists, physical therapists with whom I work closely, they learn a lot more about this. So I was thinking about more cross almost pollination, that maybe we should have an occupational therapist or physical therapist give lectures to the medical students. And maybe the medical doctors, right, who are neurologists or physiatrists or whatever, can give lectures, especially about diseases that, are inherently lead to disability, like muscular dystrophy, for example. So I think we both were College of Medicine can learn from health-related professions and vice versa. And I think that would also lead to further collaborations like multidisciplinary clinics, like we were talking about this morning. But I think education is key. I don't think anybody from all the presentations right now, I don't think doctors or healthcare professionals are purposefully, or in a mean way trying to not be helpful. I think there are many factors, time, etc. But I think there's also from ignorance, because doctors haven't learned how to approach people with disabilities. So you have to develop that on your own, which is actually what I did post residency and post fellowship, because we did not get any training either when I was here as a student or when I was a resident or as a fellow. So, ideally you don't have to do that after the fact. You should actually get that during your education.
Yeah, great. Thank you. I couldn't have paid you better for a commercial, Doc, on that. There's a fellow who's now deceased named Mike Hammer. He used to talk about re-engineering, and he talks a lot about re-engineering the education system in this country. He focused primarily on secondary education in terms of all these Band-Aid approaches and the fact that we haven't re-engineered it to make it be what it needs to be. Sounds like our health professionals education also needs that in a lot of ways. So we've come to the end today. I want to say, first of all, thank you to everybody who's participated, who's here, who's online through live stream, all of our panelists who are here now and some who are gone now, and previous speakers. This was the first step today to really begin to talk about disability in a health sciences university. So thank you. And If you have ideas on what the next steps will be, let me know. We're probably going to talk to our panelists and all the speakers today. And one thing we'll probably do is make sure that we try to disseminate the live stream recording from today around to other people who couldn't see it live today, to at least be exposed to this first step. But we got to do much more of this, obviously, on our campus. Now, in that same vein, I have a Dean's Lecture Series this year that's underway called Disability One-on-One for Healthcare Providers. We've had 5 lectures of 9. We now have 4 more to go: financing disability services, integration of disability into healthcare services, emerging disabilities, intersectionality of disability, and other key health concerns. So if you're interested, take one of these and join in. We have mostly students. That's who needs to be there primarily. And we have a 30-30 format where I talk for 30 minutes on a topic, and then we entertain conversation for 30 minutes. But we got a lot of work to do, because most healthcare education doesn't really explicitly address disability at all. So we got to make the change. Thank you for coming today. We do have an evaluation form that you should have gotten when you came in. I have it here if somebody needs it. It may take probably less than a minute to complete. 5 easy questions. And again, thank you for coming.